So preeclampsia has been described as a disease of theories because there are many linked causes. And then we're going to go through some of these potential theories. So there's the genetic susceptibility, the immune maladaptation such that rejection occurs, placental hypoperfusion and ischemia, oxidative stress, and endothelial cell injury. So I want you to just have each of those 5 little theories in your head. So the genetics, the immune system, hypoperfusion, ischemia, oxidative stress, and endothelial cell injury, because they all link in together in the theories behind preeclampsia pathophysiology. The reality, as I'm going to talk about, is that it probably involves in some way or form all of these mechanisms. And considerable evidence suggests that the placenta is the key factor in all of the manifestations because delivery is the only definitive cure. So when we're thinking about preeclampsia pathogenesis, we have to think about what's happening in the normal modeling during pregnancy. And so in a normal pregnancy, we have spiral arteries, and these spiral arteries are present within the endometrium and the myometrium. And they're remodeled by your NK cells, your natural killer cells, and your trophoblastic cells, the cells that are lining the blood vessels, to a depth that penetrates through the endometrium and into the myometrium. So this is what you can see here. You can see your NK cells, you can see your endometrium, and you can see your myometrium. And so this image is obviously in a non-pregnant endometrium in the secretory phase of the menstrual cycle, just before menstruation. And what happens during a normal pregnancy, you can see the trophoblasts, you get trophoblastic invasion of the endometrium. This leads to endometrial arterial remodeling and dilation of these spiral arteries, and therefore an increased blood flow, which can deliver nutrients to the growing placenta. So in pregnancy, the spiral arteries are remodeled by the trophoblastic cells and the NK cells. And when the spiral arteries are remodeled to a depth that penetrates the myometrium, it allows the vascular changes to allow enlarged vessels, which become enlined with the endovascular trophoblastic cells, which are the ones you can see in the image on the right. And that complete remodeling takes around about 20 to 25 weeks. And of course, this means that we have increased blood flow, leading to increased nutrients and oxygen delivery, which is reduced with failed trophoblastic invasion in preeclampsia. Because remember, the trophoblasts form the outer layer of the blastocyst, which provides the nutrients to the embryo and develop into the large part of the placenta. Just so that you know, the decidua, which is written on the right-hand side there, that just means remodeled endometrium. So you can see non-pregnant individual, you can see a normal pregnancy with the remodeled spiral arteries allowing lots of nutrient delivery. But if the trophoblasts fail to invade properly, then you don't get that proper remodeling of the spiral arteries. And so this might be some part of the causes of this may be because of defective blastocysts or placental implantation, because of the failure to express appropriate cell adhesion molecules, that's CAMs. This is linked to your genetics defects, is what we're going to talk about. So remember, on the left-hand side, this is your normal pregnancy with the normal remodeling of the decidua and the normal remodeling of the spiral arteries. And if the invasiveness of the trophoblast is defective in preeclampsia due to failure of the secretion of appropriate cell adhesion molecules, either the amount or the correct structure of them, the spiral arteries may not be able to dilate sufficiently. And you can see in this case, the spiral arteries have not dilated as much in the preeclampsia image as they have in the normal image on the left-hand side. And this would lead to poor placental perfusion and poor development. Because, of course, trophoblast invasion is not an all-or-nothing event. There is a gradient of decrease in the percentage of decidual and myometrial arteries invaded from normal, which is what you want in a normal pregnancy, to a complicated pregnancy, such as in severe preeclampsia. So in other words, defective trophoblast invasion leads to failed spiral artery remodeling, therefore leading to hypoxia of the fetoplacental unit, because not as much nutrients and blood can be delivered. We then think about immune maladaptation. So the trophoblast may also be rejected by the mother. So impaired invasion is also related to disturbed immunological interactions at the maternal-fetal interface. So where the trophoblasts encounter the maternal immune cells. And a defect in immune suppression, this leads to a defect in immune suppression that means the mother's immune system rejects the fetus. And this is one of those hypotheses about immune maladaptation. And there's some evidence for that. It includes things like the trophoblasts may undergo apoptosis, just as if they were under immune attack. And likewise, the placental vessel pathology resembles arteries of transplant organs undergoing rejection. So the left image that you can see there shows normal intravascular coronary artery. The right diagram shows rejection, an increase in coronary intimal thickness, and severe vasculopathy. So whilst this is an image of the coronary arteries, it's showing a similar principle due to rejections. So another one is due to reduced placental blood flow, which we've already talked about, for example, through the genetics, leads to placental ischemia. Placental ischemia leads to oxidative stress. You're not getting the nutrients and the oxygen getting there. And that oxidative stress and the production of reactive oxygen species, for example, can lead to endothelial cell injury. So if we have a decrease in our placental blood flow because the spiral arteries haven't been remodeled correctly, this can lead to hypoxia and ischemia. This leads to a more reactive oxygen species and upregulation of your inflammatory mediators secreted by the fetoplacental unit. This can damage the maternal and placental vascular endothelium and therefore lead to further damaged blood vessels throughout the body. And this can actually damage endothelial cells in the kidney, in the brain, in the liver, the heart, and the placenta, i.e. both the mother and the placenta, as we'll talk about later. Now, that systemic endothelial cell injury leads to an increase in angiotensin II receptor sensitivity. Now, remember, angiotensin II is a potent vasoconstrictor that is increased in normal pregnancy, but its effects on vasoconstriction are mild during pregnancy due to reduced sensitivity induced by the placental hormones on the vasculature. So remember, it's normally a potent vasoconstrictor, but during pregnancy, it has less activity, less vasoconstrictive activity specifically due to the placental hormones. But all of a sudden, we've got this systemic endothelial cell injury in this pregnancy. We now have increased angiotensin receptor sensitivity that we shouldn't have, meaning we get an increase in our vascular resistance, which of course leads to maternal hypertension. The systemic endothelial cell injury also leads to increased endothelin-1 secretion. Now that is a potent, long-lasting vasoconstrictor. So because we've damaged the endothelial cells, we get more endothelin-1 and we get more vasoconstriction, which means greater total peripheral resistance and therefore maternal hypertension. And finally, we get a decrease in the levels of prostacyclin. Now, prostacyclin is a vasodilator, and with a decreased level of prostacyclin, we get decreased vasodilation, and in essence means we're getting an increase in our total peripheral resistance and therefore maternal hypertension. And of course, that increase in our vascular resistance means we get a decrease in our placental blood flow, which means we get hypoxia and ischemia, inflammatory mediators, and you have this vicious cycle of damage to the placental unit. But why does proteinuria occur in preeclampsia? So we've talked about the mechanism behind hypertension, but why do we get proteinuria? Well, we get renal arterial vasoconstriction, because remember we're getting more vasoconstriction and it's systemic. That increases the glomerular pressure. This causes glomerular damage, and that glomerular damage makes the glomerulus leaky, and protein leaks from the blood into the filtrate, into the glomerular filtrate, which is passed out in the urine, leading to proteinuria. But preeclampsia may occur without edema. So why does edema occur in about 70% of preeclampsia cases? There are two theories. One of them is the underfill theory, the other is the overfill theory, but both of them relate to hydrostatic pressure or oncotic pressure changes that are going to occur because of pressure changes and fluid changes and volumes and volume changes. So first of all, let's have a little think about the underfill theory. So we've now got hypertension in pregnancy. We're losing proteins via the kidneys. This means we have a reduction in our oncotic pressure. That means we're getting a reduced fluid transfer from the interstitial fluid back into the capillaries at the venous end of the capillaries. This means that the fluid remains in the interstitial fluid, leading, of course, to edema. We've now got lots of fluid within the interstitial fluid, which means we have a decrease in our plasma volume. That is detected, and we get a renal, so detected via the kidneys through reduced GFR, leading to an enhanced renal sodium and water retention, and therefore we get the dilutional effect because we're retaining sodium and water. So we start to get a reduction in oncotic pressure, more builds up in the interstitial fluid, and again you get this vicious cycle. And the whole point, this is called the underfill theory because there is a decreased plasma volume. So therefore it's underfilling of the system. Remember, which triggers the renin-angiotensin-aldosterone system and further dilution of protein, leading to that vicious cycle. And of course, the increased fluid retention leads to an increased weight gain. So that's your underfill theory. We've then got the overfill theory, and this is because we get reset volume centers. So this has partially been covered earlier. So this is where you may get an increased blood volume and cardiac output. This can lead to your increased volume passing through the capillaries and therefore elevated pressure within the capillaries. And so what you're getting is you're getting more sodium, more water retention, increased plasma volume, and increased blood pressure. Okay, so we know that's what's happening in the overfill theory, and then part of that is part of a normal pregnancy. But what we're getting because of the increased blood pressure is an increased fluid transfer to the capillaries, which leads to increased transfer into the interstitial fluid, in particular because the hypertension observed in preeclampsia increases hydrostatic pressure, therefore elevating transfer of fluid into the interstitial fluid. And again, this is called the overfill theory because the system is being overfilled. There's a reset of the volume sensors, such that there's an increase of sodium and water greater than it should be. And again, because there's more water and sodium retention, we're getting an increase in weight gain. So let's have a little think about this and go through these review questions. So which of the following regarding preeclampsia pathophysiology are correct? Press pause and have a think. Number 1, trophoblasts may undergo immune attack during spiral artery remodeling. That is correct. That's the immune rejection hypothesis. Number 2, spiral arteries do not constrict sufficiently during pregnancy-induced remodeling, leading to reduced blood flow and hypoxia. That's incorrect. The spiral arteries do not dilate sufficiently. They're constricted too much, and that is what's leading to reduced blood flow, hypoxia, reactive oxygen species, etc. Number 3, hypoxia of the fetoplacental unit leads to an inflammatory response and systemic endothelial cell damage. That is correct. And remember, damage to that endothelial cells causes increased total peripheral resistance. Number 4, endothelial cell damage in preeclampsia causes release of vasodilators and increases vascular resistance. That's incorrect. You get increased vasoconstriction, such as endothelin 1, increased sensitivity of the vasculature to angiotensin 2, and decreased prostacyclin, which is a potent vasodilator. Number 5, edema may occur in preeclampsia due to loss of protein from damaged glomeruli and associated elevated oncotic pressure. That is incorrect. It's a decrease in oncotic pressure. Also, the increased hydrostatic pressure may potentiate that edema as well. So in severe preeclampsia, there's damage to maternal blood vessels leads to lots of other potential effects. That hypertension can lead to a stroke in the mother, either ischemic or hemorrhagic. Severe preeclampsia can lead to eclampsia, so those tonic-clonic seizures. And severe preeclampsia can lead to the HELP syndrome, and that's something we'll talk about in a few minutes. So hypertension, as you'll already know, is a major cause of stroke. So hypertension can stress blood vessels, causing aneurysms, but by the same token, leading to aneurysm bursting, leading to a hemorrhagic stroke. It can also cause plaques to rupture off artery walls and block brain arteries, causing an ischemic stroke. It can also lead to eclampsia. So this is a life-threatening complication of preeclampsia, and it's defined as tonic-clonic convulsions in a pregnant woman in the absence of any other neurological or metabolic causes. And they're basically tonic-clonic seizures are a type of generalized seizure that affect the entire brain. It's not known exactly what causes the trigger from preeclampsia to eclampsia, but it's seen when the blood pressure is very high, and like I said, possibly causing aneurysms in brain blood vessels, as well as hypoxic episodes due to damage to vessels, and that might lead to the fits observed. But the exact trigger or causes of triggers are unknown. So there's the tonic phase, hence why it's called tonic-clonic. So this is where consciousness is lost quickly. Skeletal muscles suddenly tense with stiff and extended limbs, and that can obviously lead to people falling over. There are brief vocalizations, for example, a loud moan or a scream, because the air is being forcefully expelled from the lungs, but it only lasts for a few seconds in general. You then get the clonic phase, and this is where the muscles start to contract and relax rapidly, causing convulsions. It's exaggerated twitches of the limbs to violent shaking or vibrating of those stiffened extremities. The eyes may roll back or close, and the tongue often suffers bruising or lacerations sustained because of strong jaw contractions. And because of the physical and nervous exhaustion, sleep with heavy, laboured breathing invariably follows a tonic-clonic seizure, and confusion and complete amnesia upon regaining consciousness is usually experienced, though this slowly wears off as the patient gradually becomes more aware that a seizure actually occurred. And severe preeclampsia can also lead to the HELP syndrome, and this just stands for hemolysis, elevated liver function tests, so liver damage, low platelet count. Because remember what's happening. The hypoxia that's occurring during preeclampsia leads to upregulation of inflammatory mediators secreted by the fetoplacental unit. This damages the maternal and placental vascular endothelium, and those endothelial cells are in the kidney, they're in the brain, they're in the liver, and they're in the heart. There is a risk of disseminated intravascular coagulation, that's also called DIC. There's a risk of cerebral hemorrhage. There's a risk of hepatic failure and also acute renal failure. And thrombocytopenia, which is your low platelets, is due to platelet deposition at the sites of endothelial injury. So severe preeclampsia can lead to the HELP syndrome in the third trimester. So if we're looking at exactly what's happening at this point, or a summary of what's happening, you get this low placental blood flow leading to hypoxia and the release of inflammatory mediators that we've already talked about. This can lead to the systemic endothelial injury, leading to hypertension, oedema, and proteinuria. We've already talked about the mechanisms for that. And in severe cases, this can activate the coagulation cascade, leading to intravascular clotting and resulting hypoperfusion. So we've now got this intravascular clotting and hypoperfusion going on. Of course, because we've got this clotting going on, the platelets have been consumed, which is leading to the low platelets. That's the LP at the end of HELP. So we've got low platelets because the platelets have been consumed. And you often get cross-linking of fibrin within the small blood vessels. This causes squeezing of the red blood cells as if through a strainer and their destruction, which is also called hemolysis. And that leads to destruction of your red blood cells and a hemolytic anemia. And platelets are consumed during this process of clotting, of course. At the same time, this clotting of within these blood vessels is occurring, a lot of it's occurring in and around the liver, which means the downstream hepatocytes or liver cells suffer ischemia, and that can lead to hepatitis. And that's your elevated liver enzymes, the E and the L. And we've done the hemolysis with the H. And of course, the coagulation factors, they may also start to run out, which can lead to severe bleeding in some cases, for example, cerebral bleeding. And of course, because of a reduction in GFR, it can lead to acute kidney injury. So as you can imagine, the HELLP syndrome can lead to significant maternal mortality. So what about pre-eclampsia pathophysiology in the fetus? Because of course we separate them into maternal and fetal consequences, but reality is they're generally occurring simultaneously. So the fetal consequences, because of reduced placental blood flow, may lead to a restriction in intrauterine growth, and therefore small for gestation age babies, so SGA babies. It can lead to prematurity because you require early delivery because of the significance of severe preeclampsia. And of course, babies may suffer brain damage in severe cases. Management, obviously, mothers should refrain from alcohol and tobacco, which can obviously increase blood pressure. Salt restriction doesn't tend to be recommended as a general rule. Antihypertensives, such as ACE inhibitors, aren't necessarily good because they may reduce placental blood flow, therefore affecting fetal development. And in particular, when I'm thinking about ACE inhibitors, they can actually cause injury to the fetus when given in the second and third trimesters, for example. And of course, delivery is curative, hence why the pathophysiology is thought to all revolve around the placenta itself. So finally, just last little review question. So which of the following regarding preeclampsia complications are correct? Press pause and have a little think. Number 1, eclampsia usually occurs when systolic blood pressure is greater than 160 millimeters of mercury. That's actually correct. Remember, eclampsia tends to only occur in severe preeclampsia, and it tends to be when the systolic is very high, above 160. The tonic phase of a fit involves tensing of the limbs and usually only lasts a few seconds. That is also correct. The clonic phase of a fit involves exaggerated muscle twitching and rolling back of the eyes. That is correct. Number 4, if endothelial cell injury is severe, local coagulation may occur, leading to hemolysis, hepatitis, and an elevated platelet count. That's incorrect. That local coagulation reduces the platelet count. The hepatitis is due to the blockage to the liver. In hemolysis, hemolysis occurs as the fibrin clotting squeezes red blood cells, leading to their destruction. Obviously, there's also the potential for kidney disease and excessive bleeding due to the reduced platelet count.